So today I would like to talk to you about a very important concept in iron metabolism, which is called transferrin saturation. So we just put it transferrin saturation. Right. So what is transferrin saturation? Now, first thing to understand is if you look at the word transferrin, it's got the part trans, which refers to transport, and ferrin referring to iron. So transferrin is the molecule that transports iron around the body, and this is important because free iron is toxic. So we do not want any free iron around the circulation, or very little of this, because it would potentially damage cells. So if we look at transferrin is a molecule like this. It's got two seats or binding spots for iron, and would carry any iron that comes into the bloodstream. So let's say this is the duodenal cell here, iron comes in, and any iron that comes from the GIT into the bloodstream can then be bound to transferrin, and you can see that either one or two seats can be taken up on the transferrin molecule, and then this transferrin molecule will move around the body and go and deliver the iron where it is needed, for instance in the bone marrow. It can of course also, let's just draw another one here, it can also pick up iron from the macrophages, where iron is often recycled out of old red blood cells. So the macrophage can also deliver iron to the transferrin molecule, and then this iron will go round and round, be delivered by cells and recycled again from the macrophage. You can get some iron that is not bound to transferrin, and this we call non-transferrin bound iron, or NTBI, and this is actually a dangerous form of iron because this iron can cause damage to cells. So why would it be important for us to know about transferrin saturation? Well, transferrin saturation can tell us whether there is too little or too much iron going around in the body, and this can be very helpful to diagnose certain diseases. So normally when you look in textbooks, you will see that they talk about transferrin saturation as being the amount of iron, serum iron, which is the iron bound to transferrin, divided by the total iron binding capacity times 100/1, which will give you a percentage. So let's just put percentage up here because this is how it is expressed. So you can see that you need to understand what this total iron binding capacity is to understand what would influence the final calculation. So in terms of total iron binding capacity, I'd like you to think for a minute about a city with many buses. So let's draw some buses here. Okay, so let's say this is a bus, and in the bus there are 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 seats, and there may be another bus there. You can see the buses here in this city looks very different from each other. Let's take another one here. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So if we look at this, you can just see that we've got 3 buses, each have 10 seats, and in total there would be 30 seats available. So the capacity of the bus service to carry passengers, if there are only 3 buses, would be 30. So 30 passengers can be carried in the bus service of the city. And then of course one can say, okay, so how many people are actually on the bus? And let's say we've got one person there, and another person there, and another person there, and another one there, and another one there, and so on. So we can say 1, 2, 3, 4, 5, 6, 7, let's make it 8, 9, 10 seats are taken. So 10 seats out of the available 30 are taken. So we can say the bus service is 30% or 1/3 saturated with passengers. Now in iron transport, it's very much the same, except that the transporter that we talked about, which is now transferrin, has 2 seats. But some of these transferrin molecules may have only 1 seat filled, some may have both seats filled, and others may have no seats filled. But if you calculate all the seats that are taken together, one can see here that will give you serum iron. And if you look at the capacity, in other words, how many of these molecules are there available to carry iron, like in the bus service there, plus the number of seats on each molecule, which is fixed, only 2 seats per molecule, then you get the total iron binding capacity, which actually tells you how much iron can be bound by the total iron transport service, which in this case is transferrin. So this, if you look at it this way, the total iron binding capacity reflects thus, just like the bus service, the number of seats, which is fixed, 2 per molecule, and the number of transferrin molecules. So in other words, when we think of transferrin saturation, one can see that it will be determined by the number of seats taken and the number of transferrin molecules that are available. So I'm going to rewrite this just to make the whole thing easier to understand. So we will rewrite this formula as transferrin saturation, and we'll abbreviate it like this, SATS, more or less equates serum iron over transferrin molecules. Anything thus that will affect serum iron will change this, and anything that changes transferrin will change the transferrin saturation. So for instance, I can quickly show you. The liver is responsible for producing transferrin. So if you have liver disease, the transferrin will go down. There will be less transferrin produced. And if that is the case, then the transferrin saturation value, iron over transferrin, will go up. So the saturation is now increased. And this is exactly what we see in patients with liver disease. I'm going to draw it in the middle. The transferrin saturation can potentially be low. Normally transferrin is about 30% saturated, or somewhere between 20 and 50. That would be the normal value for most laboratories, but it may vary a little bit. So anything that is below 20 would generally be considered as too low, but this may vary. We said that anything that will either decrease serum iron or increase the transferrin will decrease the saturation, the decreased transferrin saturation. And some examples of this, and you will see how easy it is to understand now, would be iron deficiency anemia. This is very common. So if you lose iron through bleeding, so let's draw some blood drops here. Let's say you are losing blood, then you are losing iron. And if that is the case, the iron here will decrease, and that will lead to a lower transferrin saturation. Interestingly enough, in iron deficiency anemia, transferrin increases. The body actually tries to compensate by increasing the transferrin production, which further decreases transferrin saturation. So iron deficiency anemia, either from bleeding or from decreased iron intake, will lead to a lower transferrin saturation. Another very interesting one, and this will help you a lot, because anemia of chronic disease is sometimes a difficult concept to understand and to remember what happens exactly with the iron parameters here. And I'm quickly going to show you by example of anemia of chronic disease caused by infection. Microorganisms, especially bacteria, depend on iron for their growth. So if there's a lot of iron available in the circulation, these bacteria can grow and become more. So what the body does to prevent this is it tries to keep the iron away from the microorganisms by locking the iron up within the cells that normally contain them. So this would be the duodenal cells where iron is absorbed, and the macrophages where the recycling of red blood cells take place. And you will remember from one of my other videos that iron, when it is absorbed, comes into the bloodstream through a molecule called ferroportin. Ferroportin literally meaning iron door. It gets out through ferroportin, and what the body does, it produces, by the liver again, interestingly, a molecule called hepcidin, or some people would say hepcidin. And hepcidin or hepcidin basically inhibits the ferroportin, and iron cannot get into the bloodstream. So the serum iron will now decrease and not be available to microorganisms, and thus the transferrin saturation will also decrease because of the serum iron that is lower. Now, when we talk in another video later about serum ferritin, you'll also understand now that if the iron remains inside cells, not only here but everywhere, then the ferritin will be increased because there will be more storage iron, and the liver also produces more ferritin, the storage form of iron in anemia of chronic disease. So then you can quickly work out that with anemia of chronic disease, serum iron will be low, transferrin saturation will be low, and ferritin will be high. While in iron deficiency, serum iron will be low, transferrin saturation may be low, and ferritin is usually decreased because there's a little iron to be stored. So that's another nice one to remember. If you have anything that would affect this ferroportin molecule, such as a mutation, there's for instance a mutation that would affect the ferroportin molecule so that iron that is recycled by the macrophage from red blood cells can't get back out into the circulation. It's sort of stuck in the macrophage. Now that kind of ferroportin mutation, let's just write that here, ferroportin, I'm just going to say mutation, or will also lead to a decreased transferrin saturation because there's little serum iron available. Now there are some conditions that could change the transferrin and actually cause the liver to make more transferrin molecules, and this happens for instance in pregnancy. So let's just write there, pregnancy, or hormonal contraceptive therapy. So in both these instances, transferrin production would increase, and this would cause a relative decrease in transferrin saturation. On the other side, one can have an increase in transferrin saturation. Now, normally we would say a transferrin saturation above 50% would be abnormal, at least in females, and certainly above 60% in males. And therefore this any value that is usually higher than 45%, some books would say 50%, would be a reason to screen a patient for conditions of iron overload. And it's usually when this transferrin saturation goes above 60% that one sees this non-transferrin bound iron appearing in the blood, this toxic iron that we do not want, that will be damaging to cells. So when will this happen? Well, there's a condition which is not that uncommon actually, called hereditary hemochromatosis, whereby people are born with a genetic abnormality that leads to increased iron absorption. So the iron absorption increases greatly, and therefore the transferrin saturation will go up. The same is true for transfusion related iron overload. So every unit of blood, so let's give this patient a transfusion quickly. So let's say this is the blood bag and we connect it up to the patient. Each unit of blood contains 250 milligrams of iron. That's quite a lot. If you think about it, you only absorb normally 1 to 2 milligrams per day. So 1 unit of blood gives 250. Examples of this would be patients who are chronically transfusion dependent, such as those with aplastic anemia. Let's just write aplastic anemia or myelodysplastic syndromes. There are many others. Diseases that cause bone marrow failure typically, and which requires long-term transfusion support. There are also conditions that lead to ineffective erythropoiesis. So a lot of activity is happening in the bone marrow to try and make red blood cells, but it's not very effective. And when this happens, the bone marrow sends a signal. Let's just try it. A signal whereby absorption is increased. And conditions that we think of here would be things like thalassemia. I'm just going to say thalassemia, sideroblastic anemia. There's something called black fan diamond anemia, which is a congenital condition, and many others, whereby there's ineffective erythropoiesis leading to increased iron absorption, increased serum iron, and an increased transferrin saturation. You can imagine that, of course, any patient or any person who's taken an overdose of iron, which is very toxic, can also develop a very high transferrin saturation, because now they have taken in huge amounts of iron and all these seats will be filled. Similar to what we saw on this side with pregnancy and contraception leading to an increase in transferrin by the liver, liver disease, let's just write here, liver disease, can of course lead to liver failure or just a decrease in the production of transferrin. There's a very rare but interesting condition whereby antibodies can be made against transferrin molecules, which leads to the destruction or the removal of these molecules. And because there are very few molecules around, there will be very few seats around, so transferrin will again decrease and the transferrin saturation will increase. So in summary, it is important to know about transferrin saturation because it tells you when it's very low that one should consider conditions like iron deficiency or anemia of chronic disease and some others. On the other hand, an increased transferrin saturation is also very important because it may indicate iron overload, which is a very important condition to recognize because it is usually something one can treat very well. So I hope you enjoyed that. In some other videos we will talk about other laboratory parameters by which we can determine iron status, which will complement the video you saw today. But transferrin saturation is such a commonly used marker that I think it's important that every medical student or every doctor knows how to interpret it.